Welcome to the Voices of Otolaryngology podcast series, where we spotlight diverse perspective and insights within the field of otolaryngology. I'm your host, Rahul Shah. Let's jump into it. Well, hello. I'm here at the Triological Society combined meetings, and I was able to bump into my great friend, Dr. Thompson, and I have a phrase, it's called, sometimes you just get lucky. So I'm lucky that I get to speak with you today.
Well, it's really a pleasure to always connect with you.
Yes, you say always because our secret is we've known each other for quite a while, and many in our specialty look to you as mentorship. So I know that's a big part of what you do.
Yeah, mentorship is what makes us great. Mm-hmm. It really opens the doors and sets the stage and allows us to give to others, mm-hmm. and we learn in the same process mm-hmm. of mentoring. I would say of all the things that we do as professionals, mentorship is probably at the core of my heart.
Mm-hmm. Well, we'll get there in just a second. Do you mind telling everybody your official titles? You have a lot. Oh. So I can the whole podcast could be Dana Thompson's titles.
Well, I think over time you learn to mature and really focus on things that bring passion and joy. And I currently serve as the Division Chief of Pediatric Otolaryngology at Northwestern and Robert H. Lurie Children's Hospital. I previously served as an ambulatory leader at my institution also. I also serve as the Executive Vice President for the Triological Society. Mm-hmm. And that's what we're here at this meeting today. Trio really is, we're both members.
Yes, fellows. Is there like a fellow count? Okay, we're both fellows.
Both fellows.
What was your thesis, by the way?
My thesis was on the etiology of laryngomalacia.
Oh, right. It was a landmark study. Thank you. We all use it. Mine was using a socioeconomic database looking at epiglottitis. But your study was awesome. I remember that.
So yeah, great I remember contribution. Your study too, because I have an interest in the socioeconomic care delivery models.
So tell us more. We are both here as Trio fellows, mm-hmm. but we're also members of the Academy.
Yes.
And you are also a leader in many other specialties. But tell us about your Triological Society role.
So I've been involved in the leadership team of the Triological Society for about 12 years. Mm-hmm. Served as the thesis committee chair for 7.
Wow. And wait a minute. Then Dr. Denani, isn't he a fellow?
He is.
That's my predecessor, folks, and he won an award.
Funny story. I don't know if you know that Miles Penzak, our current DVP, challenged Jim to join the Trio.
Wow.
And he did write his thesis.
Wow. And he won the award.
I mean, it was really...
That's awesome.
It was a landmark piece of work.
Oh,
looking
that's
at
terrific.
A large database for, sinonasal disease.
That's great. Well, it makes me think Joe Kirshner was recognized today, and he used the word inclusive excellence. So here we are being inclusive with Dr. Denani, and then he won the award. Yeah. So, but please, I interrupted you. You were telling us about Triological Society, and we're here.
Yeah. I think for me personally, in my own career journey, the Triological Society, I came from a residency program where it was very clear that if you were going to have an academic career, that the Trio needed to be.
Which residency, by the way?
I was at the Mayo Clinic in Minnesota.
Mm-hmm.
I would say fortunately for me, I had many mentors who valued that.
Saying back at the Mayo Clinic, you were imbued upon you that being a Trio member was important.
It was important. Yeah, and it is one's, shall we say, opportunity to contribute to the specialty of otolaryngology in a unique way because of the requirement for a society thesis. Mm-hmm. For my journey into the Trio, I don't know if you know the story, but I actually spent some time at the NIH as a medical student.
Wow. You had like 3 careers. You were like an amateur ice skater. You're a pediatric otolaryngologist. I didn't know you were at the NIH. Tell me about that.
So I was there for 4 months my senior mm-hmm. year in medical school, and mm-hmm. my whole goal was to help my application be more competitive.
Sure.
I ended up in a neurolaryngology lab studying some of the early EMG work of the larynx and airway protection.
Wow.
And then I was able to take that experience to my residency.
Wow.
And worked with Nick Maragos and Tom McCaffrey. And then I spent an additional lab studying dysphagia in a possum model. But the long and the short of this is it was that experience that I think really trained me to think about airway protection, swallowing, and neurolaryngology, and then took that into fellowship. And
do you mind telling them where your fellowship was?
Fellowship was at Cincinnati Children's.
We're just trying to call out all your programs because we have the purple for Northwestern. Is that right?
Correct.
Okay, just for the record. Okay.
Yeah, so fellowship was at Cincinnati Children's, and so when it comes to the work that became the landmark of the thesis, I had been studying sensory testing of the larynx.
Yes.
Was an innovation of John Aviv to understand airway protection. I had been doing that in adults, and partnered with Paul Wilking in Cincinnati at the dysphagia clinic. And Robin Cotton had a patient travel from New Jersey. So
that's local for Robin Cotton. That was local.
That was local. You know,
New Jersey.
New Jersey to see the world famous
for Dr. Cotton.
For severe laryngomalacia.
Yes.
The child of a hockey player, and I grew up in a skating rink. So Robin just said, "Why don't you go see the patient? And what did you go do?
Because hockey and ice skate,
exactly. Why don't you do that sensory testing thing? Understand the swallowing, the child's not swallowing.
Sure.
And that was the outlier. The lesson is paying attention to the outlier. So we delivered this air pulse. The child didn't feel it. There was no response.
6-year-old?
No, an infant.
Infant, yeah.
So there was.
So you did a puff of air.
Vocal cords didn't close.
Wow.
Swallow response didn't trigger.
Wow. So we would have missed that if you had, if they would have come to me, because I wasn't doing that.
Yeah. And
very cool.
Did the supraglottoplasty, and we restudied the swallow afterwards because this child was feeding fine.
Yeah.
And redid the sensory testing, the child had all of a sudden feel.
Okay, so how did that work? Because in supraglottoplasty, you remove tissue. So how did you get, what do you think?
I think that once you remove the tissue, you're better exposing the superior laryngeal nerve.
Yes.
And so it's activated.
Brilliant.
And it's a sensory connection between the larynx and the brainstem that protects the airway. So, that was how we discovered.
That is so smart.
It was just seeing the value in the outlier.
Gosh, that's so smart. I'm not trying to dumb down what you did, but it's genius.
So lo and behold, we studied.
So then you started asking the question.
And prospectively studied children over a 5-year period of time. And what we found is those with severe laryngomalacia needing airway intervention or swallowing issues took a much higher stimulus to generate vocal cord closure and a swallow response than those
with sensory testing.
And
you showed that.
Than those who had mild laryngomalacia. And we followed them over time, so we saw that they all eventually normalized to what would be an adult normal sensation.
So cool. How much time did it take to normalize?
About 6 months. So it's a neurodevelopmental disorder.
But that's how we counsel parents. It's not going to be a panacea, right? The breathing might get better, but And that's all right. Well, you keep talking because you continue to educate me.
Yeah, so that was.
You can talk about anything. You'll probably educate me.
So that was the basis of.
But then the modern day aerodigestive clinics, right? Those are popping up all over the place.
Yes, and this was before.
I know.
Quote aerodigestive.
Yeah. So talk about that. That's so cool.
The evolution of aerodigestive medicine is really quite fascinating, and you know how it was. We were practicing all within a silo.
Of course.
Interrelated.
And define it for our audience. Pediatric aerodigestive clinic. Who do you have there when you do it?
So an aerodigestive disorder is a child who has difficulty breathing, swallowing, protecting the airway, recurrent respiratory illnesses, chronic dysphagia. So within a modern aerodigestive evaluation or clinic, it's usually otolaryngology, pulmonology, and gastroenterology. Many of our programs have gone on to expand, include pediatric surgery for surgical management of reflux disease or proximal esophageal disorders. Many of our clinics have also started to include a much more holistic look. Like we have a social worker embedded into our clinic, which we find incredibly important because the burden of, shall we say, changes in life from a child with an aerodigestive disorder is not small.
Yeah.
And these families really need help not only navigating the system, but navigating their environment in caring for a child.
So the captain of the ship for aerodigestive is otolaryngology?
It depends on which institution.
Yeah.
Many of them are laryngology based. Some of them are much more medicine based.
Yeah, sure. All right. So then talk me through your career. You did that with Dr. Cotton, and then you developed quite a name, reputation in the scientific community for your acumen, but then you moved up northwest.
No, so I was at Mayo Clinic.
Oh yeah, you went south and then you went back up.
Career Cincinnati Mayo Clinic, and now I've been in.
That's right, Cincinnati Mayo Clinic. Then you came south. Sorry. And then why did you move to Lurie Children's?
The job found me.
Yeah.
I wasn't at a career point where I was seeking a different leadership opportunity.
Sure, but you were super recognized in the field.
What inspired the move was moving to a large metropolitan area.
Mm-hmm.
As you know, Chicago is a city of 11 million people who all walk into the children's hospital.
Yes.
With a varied socioeconomic
patient
population.
And that's important to you, correct?
It's important to me to really demonstrate value.
Sociodeterminants of health are important to you.
Yeah, I have the fortune of being a third generation Black physician.
No way.
So
I've seen this talk before. Hold on. So don't say that fast. Third generation African American physician. So who was above you?
So
Mom
my grandfather on my mother's side was a family practitioner.
Oh, that's so cool.
In northeast Mississippi.
Wow.
He was probably one of the few Black doctors for about 100-mile radius. And
what years did he practice?
He practiced from 1927 to 1979.
Can you imagine practicing during that time?
No.
Wow. So cool.
I learned of his legacy through stories.
Did you get to know him?
And I did get to know him. I mean, he was still seeing patients in his home office when I was...
Yeah, don't tell me when you were born, but you can tell me.
But shortly thereafter.
You remember seeing...
I remember him. I mean, I was 8, 9,
Yeah,
10,
but you have a memory
11,
of him seeing...
12.
That's
I have
crazy.
a memory of him seeing patients.
That's insane.
He still made house calls. He grew up in an era of complete segregation. He traveled to his patients.
Where was his med school?
He went to Meharry. He was in the class of 1927 in Meharry.
I get chills. Yeah.
So that was the first class at Meharry after the Flexner report.
Wow, so that's your mom's dad. All right, and then the second generation?
So is my father.
So your father.
My father was in obstetrics and gynecology, and he...
and where was his practice?
Kansas City, Kansas.
Okay.
He was one of the early integrators of a residency program in Kansas City, from a segregated hospital to an integrated hospital. He also graduated from Meharry.
Oh.
He chose to practice obstetrics and gynecology in an inner city in Kansas City, Kansas.
He chose that?
He chose that. His practice with 2 other partners, it was a private practice, was focused on urban healthcare. And at a time where premature birth rates were very high for high-risk obstetrical patients, his small private practice did 2 interventions that reduced the preterm labor rate.
What were they?
Prenatal vitamins, making sure that the women had prenatal vitamins and transportation to care. Access and transportation.
And those 2, would it drop the infant mortality or
and having access to ultrasounds?
Those 3 things.
Those interventions.
That's insane.
Alone, and his practice always made themselves available to their patients. And so in his community, they were able to drop the preterm labor rate. This is well before the concepts of social determinants.
So he went into the inner city. He had a not affluent population in a private practice.
Correct.
Fascinating. Yeah, and so then where did you go to med school?
University of Missouri in Kansas City. It's a 6-year...
You didn't get into Meharry?
No,
I'm not. That's fine.
I chose a 6-year...
So wow, so you're a prodigy.
Yeah.
So you did this 6-year program in Kansas City.
I did.
All right, then you started your journey. So then coming back to Chicago, did you feel some of that pull?
That was one of the reasons why I chose to go to Chicago, was to
11 million patients.
To be able to contribute to a community where the opportunities for access and what might we be able to do to contribute to lessen the gap in health disparities and outcomes.
You've created one of the top programs in pediatric otolaryngology. I know that because that's the word on the street. It's not a team. You get the best fellows. We know. Congratulations. How long have you been there?
12 years.
Wow. So what have you done culture-wise, community-wise? What are perhaps some of the wins when you look back there, what you've accomplished? And I'm still trying to add up because things don't add up with your career. I mean, you have like 2-3 careers in your, mid-career.
I would say I have lots of interest. I'll give you 2 tests of change that I think really made
love
a
it.
difference.
Yeah, I love the word, using that word. Go ahead.
So we have clinics with the majority of our patients speak Spanish.
Okay.
And I mean, how
do you speak
it is.
Spanish?
I don't speak Spanish, unfortunately.
You do not?
I do not. But you know how it is. You're trying to get a Spanish interpreter on
Absolutely.
an iPad or a teleprompter.
Yeah, my favorite
that,
thing.
And the other. We decided to employ a Spanish interpreter in our practice.
On your P&L, on your expense report.
One of my chair funds.
Wow! So you used your endowment chair funds.
An endowment chair to employ a full-time Spanish interpreter. And as we integrated the Spanish interpreter into our practice, here were some of the tests of change.
Amazing.
We had the Spanish interpreter.
I'm going to interrupt. Yeah. Is your father still around?
No.
Okay, so he'd be so thrilled. Yeah. Okay, because you told me what he did. Yeah. Look what you did.
So
crazy.
We employed the Spanish interpreter full-time in our practice. Mm. A few interventions. Had the Spanish interpreter call the families in advance. Do you have transportation?
It gives me chills. You took your. Come on, you give me. And this is your dad's playbook.
If there are transportation issues, what can we do?
Wow.
What kind of fund, or how do you align your Medicaid or your Medicare resources for that? The additional thing is having the Spanish interpreter in the clinic change the cycle time, meaning the start to the end for the care episode. It decreases cycle time per patient in our clinic. We actually studied this and published it by 9 minutes.
What percent was that?
But what that allows you to do is add incremental patients to your schedule and increase access.
And your no-show rate probably went down.
And our no-show rate went down.
I'm embarrassed. You're talking about access, and I'm thinking revenue. So your no-show rate went down, and you had more slots.
But it is. But
I know you're doing the right thing.
But that's how we're going to solve some of these challenges with American healthcare delivery.
So access improved by how much?
Well, we were able to add 2 to 3 more patients per clinic
per session
by doing this.
Yeah, I can't do my math. That's almost 5-10% increase.
And then when you look at it from a revenue perspective, if you think of the revenue is if you have a 1 to 4 conversion ratio to surgery, or you have a 1 to 6 conversion ratio to an audiogram or to a CT scan, then there's a revenue component to it, but more patients are getting care.
That's awesome.
Now take the math. I know you're.
My numbers are going. I'm already here. 15%.
You're a number guy. You're a number guy, and you're a financial guy. So, what if in your institution you had a Spanish interpreter embedded in the clinics and the highest volume of Spanish-speaking patients, and we did the actual actuarial statistics, and if we apply that across the entire organization, we found that we could get 39% more capacity in access.
Wow.
If we applied it across the entire organization.
You don't have to tell me if the hospital did that or not, but you made the business case. Wow.
I made the business case for it.
So you have an interpreter still in your clinic?
We still have an interpreter.
From chair funds or operations now?
Still chair funds.
Yeah. That's incredible. Incredible.
But it's like if you look at United States compared to other developed Western nations, for what we spend, our performance isn't any higher. We're not living any longer.
Yeah.
And we underperform in performance and in equity.
Yeah.
What do some of our more developed countries that perform higher do? They invest in some of these social resources, whether it's a social worker or other.
May I ask, I'll throw a number out there. So that interpreter, let's say total benefits all in about 100,000 of Chicago. Less, Yeah, so part of this podcast is to spread learnings. And this is agnostic to private practice because you're actually showing me an ROI. So if you're in a certain environment where you're frustrated with Marty's, you're frustrated with an interpreter, maybe actually you can do the math and bring one on, right? That's what you're saying. Some of our practices are huge out there, Dana. Yeah, so great idea.
Right. Well, if you look at the value-based equation for medicine.
Yeah, define it, please, for our members.
So
go ahead.
The numerator is quality, outcome, patient experience,
yes,
and the denominator is cost.
Yes.
So the more that you add into improving the patient experience, and in this case, the Spanish interpreter in the numerator, experience for the patient is better. Compliance to care increases.
Yes.
provider satisfaction and the patient care interaction improves. That's all part of that experience. And the numerator, it adds value in the long run. I mean, if I were reworking that equation on value-based medicine, I would also add, the social determinants of health, and attaching that to the value in the numerator is really what is going to help drive quality and improved outcomes. And the investment in that infrastructure, we already talked about the Spanish interpreter. We haven't even mentioned some of the work that our team under Tahir Balika's leadership, where with our aerodigestive kids, we have a very small fund that helps with travel.
Wow.
And, we have less patients lost to follow up with trach follow-up and, those type of complications.
How is your division? It's a division. Mm-hmm. How's your division doing financially? Strong?
I think every organization is challenged with modern day reimbursement. We're definitely hitting budget and exceeding.
But now, so I've known you forever. Now I know why you keep getting promoted. I mean, way to nail it. I mean, people talk about value-based care, but they actually don't give a tangible example that has dollars, improves access. I mean, you did the trifecta. It's very rare. I live in a value-based world, quality and safety. It's pretty unusual to find such a case exemplar that you did. And we were just split between our recordings a second ago. What is your passion in healthcare?
Changing the outcome, but probably most importantly is inspiring the next generation to think differently about how we deliver care. It's one thing to learn a diagnosis, learn how to treat a patient, learn a surgical procedure, but it's really looking at the patient holistically.
So can I tell you your reputation out there? Do you want to know? We're getting recorded. You're known as a master surgeon. People think so highly of your surgical skills, but you're talking about soft skills, right? You're talking about interpreter and access. Is that amazing? You could have probably come up, and you probably have, with procedures with your name behind it, but you've chosen to make an impact through value-based care. Interesting.
And I think most importantly is inspiring the next generation. I mean, the change I hope to see is not going to happen in my career.
Yeah, well, it's already happened in your career. In Chicago, that's cool.
The change that we all as a country and a nation need to see in terms of the value for the dollars we spend on healthcare is going to require all of us to think very differently and give different skills to the next generation. We need healthcare providers to understand process improvement, to understand concepts around throughput and lean management, to understand financial concepts, to understand the way to think through holistically managing the care episode. It's not like I'm going to be the interpreter.
Do you have training past? Do you have a MBA?
I do have an MBA.
And where is that from?
It's from a small name university in Chicago. I mean, when I looked at the opportunity to do an MBA, it took me about 10 years to do.
No, that's fine. I just wanted to know because you're so conversant with everything. I appreciate that. I love how you use words, tact time, test of change. It's part of your vernacular, right? It just comes out. So you have taught me through SUO, through the academy, through Trio. You have a vision of mentorship in a pipeline. Can you describe that? And I used the wrong word. What wrong word did I use? Yeah. Educate them, because you've been teaching me.
Pipeline feels restrictive.
What should I call it?
A pathway.
Explain to me. And explain to our members.
It is a pathway.
And you've gotten to be known about this, about the difference between a pipeline and a pathway. Please.
So a pipeline is the concept that there's an end goal in mind, and that we're going to get people through this, and that it's going to be challenging, but we're going to get a group of individuals through this. Pathway is a journey. And that's what this process is. It is a journey. It is a journey. I mean, if I look at my own personal experience, I am the product of a pipeline program. I did a pipeline program in high school at the University of Missouri, Kansas City. It was specifically targeted to disadvantaged and underrepresented minorities. I had this open door to understand medicine at a very early age. The importance of these type of programs is that it provides people the skills, not just the exposure, but the skills that there may be a gap in. Is there a skill gap in standardized testing? Is there a skill gap in math or science? So you have to go way upstream to really make a difference. And, opportunities that we have in otolaryngology.
Dana, you said something very important. Back up for me a second. We are the lowest performing specialty in...
We are one of the lowest performing specialty in diversity. It's when you look at people that we say are minoritized or underrepresented minorities. Specifically, if you look at African American and those of Hispanic or Latin descent, and you look at the general population of the United States, and you look at comparatively the percentages that are going to med school down the pipeline, otolaryngology, when we get to the full professor mark, 1.7% of professors are African American, and a little under 3 are of Latina descent.
And since this is an Academy podcast, I like to shout out the Academy. You explained to me something that the Academy did in Miami, which really helps the pathway. And it's something that you've been educating me on, is how do we get a pathway?
Yeah, so...
And you can keep talking about the Academy. Just throw the Academy in here.
No, it works. It's the importance is having a strategic plan for it, because it's not going to be an overnight return.
To have a pathway.
You have to have a strategic plan through the years, because it's going to take years to get there. So if you're looking way upstream, like what the Academy did, is you're in Miami and you have a skills lab. You go to a high school. You introduce these.
Did you get to go? I missed it.
I didn't get to go.
Yeah. I had to walk around and learn from Dr. Donati.
And so we have this opportunity to introduce kids to the specialty. It's built upon the orthopedic model, who they've been very, very successful. They do
Come on, they're beating us?
They're beating us in the percent increase incremental
in
every
the pathway.
Year in the pathway.
Wow.
Their strategy, which is led by a pediatric, not pediatric, but an adult orthopedic surgeon, Bonnie Mason. Her strategy was early exposure. Find high school kids, find undergrad kids, do a plating session, get bones out and plates, and introduce them to the specialty. We can do the same thing, temporal bone, foreign body, looking at an ear. Then you get a list of names over time. And then you can reach out to these students at different phases. Another part of the pathway, which is really important, is identifying, specifically for otolaryngology, is identifying people early. We've already published on this. We have published that those that come from underrepresented backgrounds, if they are identified early, year 1 or year 2, and they are mentored, number 1, they're more likely to enter otolaryngology, and they're more likely to match in otolaryngology, and they're more likely to match into residency and complete their residency.
So I'm here at the Triological Society from 6:45 this morning to 8 a.m. You had a packed room.
It was much fun.
Yeah, what was that?
Yeah,
I took a picture. I posted it on LinkedIn. It was your mentoring session.
Yeah,
room is packed.
This is the brainchild of Sujana Chandrasekhar.
Yeah, Dr. Chandrasekhar has many brainchilds. Genius,
this is
innovator.
A brainchild.
The room was packed.
Creativity.
And then at lunch, I had a table of med students with me.
So you have the brightest otolaryngologists in the entire country in one room, sitting at different tables and inviting medical students or residents or people early in their careers to sit down.
Yeah,
and
you
just
even
have
had
a
faculty there. You had to learn, right?
Yeah.
You had a mid-career, early career, late career table.
Just to sit down. I think that's really one of the it is a core value and part of the soul of the Triological Society is mentorship and promoting next generation of excellence.
Yeah. So, Dr. Thompson, of the many hats you wear, you are a leader of the Triological Society, the American Laryngological, Rhinological, and Otological Society. Define your leadership role, and you're also very active in the Academy and ASPO, pretty much in a lot of stuff. They're not separated. You kind of see them as a whole. You're moving our field forward. What is your Triological Society role?
Yeah, I currently serve as the assistant DVP for the society, which is a deputy director role. And what I really enjoy is the collegiality and having a seat at this table. And as a woman and a woman of color to have a seat at this table in an organization that is in its pathway, and we are growing in diversity. And I would say to be able to amplify the why, borrowing Joe Kirshner's words, inclusive excellence. And we know we are students of business. We know that.
Go ahead. Diverse teams outperform. What were you going to say?
I was going to say diverse teams outperform.
You were.
I was.
Boom. This is our third pound out. Go back a second, because you used one of my favorite words, amplify. By the way, commercial, these podcasts are meant to amplify otolaryngologists, so thanks for using our word. What is inclusive excellence? Explain that to the group here. And let's credit Joe Kirshner with that at Medical College of Wisconsin. He gave a wonderful short speech, and he's moved on into an emeritus dean role. He's a mentor to all of us, perhaps. But what does inclusive excellence mean, and how did he personify that or epitomize it at MCW?
Yeah. Inclusive excellence is appreciating the skills and the lived experiences and life experiences that people bring. And it may not be strictly, and he used the example of the board scores. He used that beautiful example of the USMLE was originally a certifying score, and then it became a score of aptitude, and then it became a screening point, particularly for our specialty. And so when you think about inclusive excellence, it's broadening the definition of excellence and appreciating that and seeing the value that inclusion of diverse perspectives really begets excellence.
What are some of your goals, and you and the Triological leadership, when you look forward to the next 5 years or so? If you don't have any, we'll cut this out. If you hear her answer, then she's got her goals. What would make you proud in 5 years when you look back at the Triological Society?
That we continue to evolve, as we are doing.
Good word. Yeah, want to be contemporary.
Contemporary. We started with the thesis committee.
Dr. Deschler, Dan Deschler.
Yeah. It used to be, it's the scholarly piece of work that you do. It's a unique contribution to otolaryngology, and we broadened the definition. So it no longer needed to be basic science or clinical science. Now you can flip your process improvement project into scholarly work. Sure. You can look at a technology or procedure development and flip it into scholarly work. So we have broadened the definition of excellence and gives many more people the opportunity, even people who are in private practice, an opportunity to take something that they're doing in their local environment to create something scholarly. So that is an expanded definition of inclusive excellence. A next expanded definition of inclusive excellence is going to be this pathway program. How do we partner with the Academy and with the Society of University of Otolaryngology to redefine what excellence is for the specialty of otolaryngology and assuring that we are attracting the best and the brightest and providing the substrate and the opportunities to enter into this pathway and be a successful contributor to our specialty.
We have a couple minutes left, and I always like to do some fun stuff. So if we'll just cut some of this out if you don't answer the right way. How's that?
Okay.
You've got a lot of fans. A lot of people look up to you. They want to be Dana Thompson when they grow up. What advice do you give them? The med students, the residents, the fellows that look up to you. I know, because when we interview them, they're like, I want to be Dr. Thompson. I'm like, don't you want to be me? Nobody wants to be me. So what advice do you give our young otolaryngologists that are out there young in their training?
Yeah. One advice is begin to understand what your own personal values are and how they shape how you show up. Like my personal values, I can define in 5 words. And I filter every leadership decision through this. I filter every difficult decision through this. And I would say about 99% of the time, if I feel like I've done something well, or if I haven't done if I've done something not so well, or could have done differently, and I filter it through my values, I learn where I kind of fell off course.
All right, I'm going to give you a quiz. What is your 5 words?
Yeah. So the first one is excellence.
Oh my gosh, you know them. Excellence.
Excellence. So it's unwavering excellence.
Of course. Yep.
The second is the impact of our work.
Impact. Okay.
The third is inclusion.
Mm-hmm.
And
Inclusive.
what I mean inclusion is inclusion of perspectives.
Yeah, good idea.
Innovation. Things don't change, you don't grow unless you think of this from an innovative spirit and come to work with curiosity. And the last is resilience.
Okay, you got all 5 of them.
Resilience.
I mean, they're your words, so good for you. I love that. I think it was Dr. Terrace this morning gave us a great tips about burnout and wellness and resilience. You are with trainees, you're with med students, you're in a very busy hospital. What does Dr. Dana Thompson do for resilience? Another way, how do you work-life balance, integration, whatever word?
One of the things I learned from some of my mentors is every single one of my most influential mentors had a second home or somewhere else to go.
Oh yeah, we've had this fun discussion. I think we were at SUO and you convinced me to buy a second home. But more important than that, you have a different place to decompress.
Just different place to decompress.
Yeah. So when we grow up to be Dr. Thompson, get a second home. Is that mentors, we're going to end with mentors. They shaped my career, and that's why I'm in this role. We stand on the shoulders of giants. Who are those giants for you? Who would you like to shout out to?
Shout out Robin Cotton, who was the leader.
Does he now know the difference between ice skating and hockey? Because he's not from, where is he from? Do you mind letting? He's British.
He's British. Yeah. He definitely knew the difference to begin with.
Yeah, but he just said, whatever, ice skates, go.
Your skating rink, go.
What did you learn from Dr. Cotton? He's a mentor to many of us, but very special with you. You did your fellowship.
Yeah. Robin saw the skill and talent in everybody. And he knew how to bring that out and appreciate people and their value and their contributions.
What a great legacy, isn't it?
Yeah. Another important mentor was Carrie Olson, head neck oncology surgeon at Mayo, and unwavering excellence. I think one of his other key attributes that was inspiring to me was his ability to lead through influence.
By the way, do you just know you used your Minnesota accent when you talk about Mayo? So if you all don't believe me, play it back. She just used it. That was an awesome pickup by me. But go back. How did he lead by influence?
He had the strategic ability to see all the opportunities for an organization or for an individual developing as a surgeon or for a group, and just knew how to bring them together with purpose and with value.
That's awesome. So Dr. Cotton, Dr. Olson, finding the commodity for everybody, leading by influence. Any other mentors that you want to shout out to? You don't have to.
Yeah. Oh gosh.
There are too many. All right.
I mean, there is.
No, that's fine.
There is a lot.
I know. I've seen your talks, but I appreciate that. I didn't mean to put you on the spot. And mentors of hers, she will rattle them off later, but I'm going to cut her off. What would your grandfather say?
I think both my grandfather and my father would never believe the progress that has happened in 100 years.
Yeah. I was going to say, what would they say about you? I think they'd be super proud. My God, look at the impact you're making.
They would be proud, and they would also know that they instilled a value set that has become a legacy through generations.
Yeah, I love that. Yeah, they must be so proud. You started this by talking about access and interpreters. That's actually what your grandfather was doing, right? Getting patients or going to where they, right? And your dad too. What message do you have for our future otolaryngologists out there, our private practitioners? We'll let you close us out.
Private practitioners are a very important part of our specialty.
Yeah. Our ecosystem.
It's part of our ecosystem, and I think what we're all going to learn is the value of understanding the way to run a practice efficiently and effectively, both in patient outcomes, but also from an economic perspective. Even at Trio, we are learning on our panels, having people who are in private practice describe their experience and describe these efficiencies that we all need to continue to integrate and bring into our academic worlds.
Right.
Yet learning how to to balance the two.
Yeah, I love that you mentioned that. None of our societies are specific to say academic versus private. We're all one, and I love that you use that exemplar there. Great. What do you do at Northwestern? Sometimes when we end these podcasts, we'll do like hook 'em. I learned today they do this in Kentucky because it's the opposite of Louisville, Kentucky. What do y'all do at Northwestern or Lurie Children's to end something?
I am so not like that.
You're not like that? All right, ice skating. What did you do in ice skating? You probably were silent. In ice skating, when you nailed something, you just were silent. When you got straight. You
were either silent
or you go, yes. All right, let's end. Yes. Thank you.